So the question is kind of about magnesium, and is there a certain brand? Yeah, there's not necessarily a brand per se, but there are forms of magnesium that do sometimes better job. So like if you are constipated and you just need to have bowel movement, magnesium citrate's pretty reasonable for that. If you want a more absorbable systemic magnesium, you probably have to go with something like a magnesium glycinate or magnesium hydroxybutyrate. In our case, we use a lot of magnesium hydroxybutyrate and a lot of magnesium malate also. We find that a lot of the kids have, what you would call fibromyalgia. And so when adults have fibromyalgia, there are certain things that we use that kind of reduce some of the pain that they have in their muscles. And magnesium malate and magnesium hydroxybutyrate are two of those that'll do that. Okay. So we use those quite a bit just because we want to reduce the amount of pain that they're having.
Yeah, and for him, like I started using the magnesium to stop the muscle spasms at night in his legs, which have really helped instead of doing the medication.
We love that.
And so, yeah, I was just using magnesium, but I wasn't sure which one would be better for him.
And then you go to bowel tolerance. Basically, you kind of figure out at what point are we getting loose stool or diarrhea? Okay. And then we can back down from there.
Okay.
So what's your thoughts on magnesium threonate?
So I am a huge fan of threonine because threonine does all sorts of really great things. And so magnesium threonate is just taking two of your really good friends and putting them together.
Right.
So we use that a lot also.
Exactly.
It's just more for a raw material perspective. It's just more expensive. I think maybe because there's just not as much available, not as much made.
Right.
But
I got a question for you. So hang on. So what I always theorize, right, and I think it's in the literature, is that with threonate, do we plug the NMDA receptors better versus a glycinate or other, right? Because it's getting into the brain better?
It is, but there's another element there, which is that the NMDA receptor has accessory receptors for glutamate and for glycine.
Got it.
So our other favorite, which is magnesium glycinate, which normally has a kind of a pacifying effect on the nervous system, it can also upregulate some of that NMDA activity, which we don't want.
Right. That's good to know because that's pro-inflammatory, right? Okay, cool. What about a magnesium soak, right? Because I know like some of my patients, they're doing it oral and it's not, they're not getting great results, and so I'll have them get like some magnesium flakes like online, and sometimes that's a better
Absolutely. Route. That's a magnesium chloride in most cases because it's small enough to actually come across the skin.
Cool.
And that works great. I mean, there's a measurable absorption that a person will get from that.
Nice.
For sure.
Very cool.
Hi. So I just had a question about CBD. My son, he has epilepsy, and he's on several different seizure medications, and sometimes we think some of them are doing harm than they are good. So I was curious about the CBD. Do I just go into like an herbalist and be like, which one do you recommend, or is that something I need to discuss with his doctor about? And which one do you recommend?
Well, I encourage you to discuss it with your doctor. And then make an assessment as to whether that's a good doctor or not, based on whether they're current with the times. There's a humongous amount of research being done on CBD, THC, THCV. There's so many of these. And your neurologist, your primary care physicians are fooling themselves if they think this is just a fad that's going to pass. It's here to stay because it works better than most of those medications do. There's some things that you should know. And that is that CBD sometimes gets funneled through the same pathways in the liver as some of those seizure medications do. So when you start a new thing like that, it's not uncommon for your systemic levels of the medications you're already taking to go up. Because basically they're not processing it as fast because there's something else in the pathway now. So we just have to be cautious about that. It's one of the reasons, I will say, I believe, that people find really great results from CBD. You just start with a little bit, all you're doing is making all the other seizure meds work better. That's not a crime. Then once you start introducing it, you just have to decide on whether or not that's an appropriate dose or not. Generally speaking, and this is as general as it sounds, we usually start with a 20 milligram dose twice a day. That's not rock bottom, and it's not super high. It's a pretty safe dose that gives us a pretty good response that isn't going to overend a lot of his other medications.
Okay.
So, and if I can add to it, so just full disclaimer, I do have a CBD company, so NeuroSolution CBD, but I echo everything that he said. You're going to slow down biotransformation in the liver. You can absolutely use CBD as a way if you're trying to wean medications. It's great because you get this increased effect from the medication. For seizure specifically, we've found clinically that the higher doses actually really do tend to help, but that's going to be so specific to the patient. And so literally, like he just said, starting with the low to mid-range, dosage, and then working your way up. I will also say that a lot of CBD companies out there tend to use a lot of pesticide and herbicide because it's not a cheap crop to grow.
And it's not regulated the same as other crops are.
Correct, yes. And so that is something else to really consider because that can do a lot of harm, to your nervous system. And so, like for example, we never use any kind of pesticide or herbicide. There's other companies that do that, but that's definitely something that you want to look at. And then also consider CBG. There's a full spectrum of your, I can't even say all the letters, but anyway, but CBG is definitely showing a lot of promise, not just for seizure, but for several things.
And the beauty is it's a mother, the CBG is kind of the mother endocannabinoid. So a lot of the other ones get to be converted into something else depending on what's going on with your body, which is also pretty interesting.
Absolutely.
So, is your company online? Do you just go to your website?
Yes. And the website, I don't even know what it is. It's something like neurosolutioncbd.com or something like that.
Okay, so play around, huh?
Oh my gosh.
Or call the
I'll
office.
have to find that. Oh my gosh.
Okay, I have a question. So my son, he's very complicated, but he started keto at the end of June. He's also on CBD. His neurologist is amazing. But our next step is to wean, on fee, because I really want him off the benzo. But my main question is, his gut is taking such a hard hit from the keto that we're now seeing vomit, which he never used to vomit. He's G-tube fed too, so what you said was really interesting. But how can I help that specifically?
So more so with the wean of the Onfi or
No,
with...
no, sorry. How can I, is there something, a supplement or something to help his gut? Because I think his gut's kind of having slower digestion from the keto, because it was such a stark change from his diet before. So we're seeing vomit every day. He used to never vomit, so it's been really rough, but the keto has been amazing for him, so I want to stick to that, if that makes sense. So is there just something I can give him to help his gut with that?
Lots of things are coming to mind. The answer is yes. It's going to be very specific. I would want to see a stool test. I would want to see what's going on in his gut. Do we have to go after the barrier system? Is there some kind of dysbiosis, like a gut infection? Are there parasites? All these things. Do you use oxaloacetic acid?
I do.
Yeah. Things like oxaloacetic acid might be something to add into the mix to help with really everything. But do you have any good quick answers for her? Because this is a multifactorial.
Yeah, there's so many, and it really depends on the child. It depends on the situation. What is worth talking about is that a keto diet is kind of it's a hard diet for your body to break down. It's a hard diet because normally you break things down based on what's called the law of adaptive secretion. Whatever you've been eating, your body's making the enzymes to break that down. You add something new in, and it's going to take you a little while to come up with that particular enzyme profile. Secondly, your bile production has to accommodate for this fat element. And so a lot of times what we'll do, just to facilitate especially the fat processing, because we don't want to lose calories with that too, because now you're losing weight. And so there is a preparation. I'm going to apologize for it first. So the initials are TUDCA, T-U-D-C-A, and the full name is, it's a tauroursodeoxycholic acid. That is a bile acid that is bound to taurine. And so now that will just flat out digest your lining of your intestinal tract. But if you mix it in with the fatty materials, it will change that absorbability for them and make them less irritating. So start super small, 1/16 of a teaspoon kind of a thing in a feed. As he tolerates it, then you kick it up to 1/8, maybe 1/4 of a teaspoon. It won't take much per feeding, although I have been surprised. If you're 40-year-old female and you've got gallstones, you might need a lot more.
Right. Then, are you doing anything for the vagus nerve, like to improve just the overall tone?
Just started keto.
Okay.
That's horrible seizures. But actually, the keto diet, within 3 days, he's only had 1 seizure since June.
Woo!
Nice.
So it's been amazing the effect it's having on his brain. I've also seen cognitive improvement, and CBD, I saw a lot of that too. But keto is really, I've got that.
Nice.
Imagine what a brain can do when it's not seizuring, huh?
Right. Exactly. There you go.
When he started CBD, I saw a lot of visual improvement because his seizures were less. And now he's even tracking even better now. And he's having a huge change in the last few months. So
That's awesome. That's great. Yeah. So there's several things to consider just from a neurological perspective. The vagus nerve obviously is going to control motor output to organs, helps with digestion, et cetera, right? So, and there's also research, actually a good amount of research that shows vagus nerve stimulus helps with seizures. There's also research that shows trigeminal stimulus, so, the trigeminal nerve on the face. And one study actually shows that trigeminal stimulus reduced pediatric epilepsy, so not even just seizures, actually in the pediatric population. Now, we also have to look at where those networks really coalesce, right? And so we're looking at the lower part of the brainstem. And so then what we would do is evaluate the brainstem. And so we could look at primitive reflexes, we could look at facial tone, we could check all the different cranial nerves. And that would then leverage the neurology to then fire down into the gut, into the gallbladder, and all these things, right, to help you increase the tone of that overall system for better processing. But then also with the vagus nerve and the trigeminal stimulus, you get neuropeptide release, you get modulation of inflammation, et cetera, right? So there could be a lot of potential there for you as well.
All right, so first of all, thank you for y'all's time and your knowledge. It's very imperative. But Dr. Proefrock, you were talking earlier about formula was bad, right? So my son, the history, GJ tube, G tube is where his feeds come in, G is where his water and the meds come in. Trach was removed back in May, so he's barely learning how to swallow all of that. He does do purees for pleasure foods, but very little because he's at high aspirations. What would be some of the steps to kind of get him off of that formula and getting him into maybe some blended, something to work on? We are currently working on with more of the suction motions and swallowing, but in the interim, 14 months into accident, we definitely want to remove him off of that. What would be some of the kind of like a protocol or a basics to work on?
What's the formula that you're using now?
Kate Farms.
Okay, so a better formula than most by a long shot, and still has sometimes some issues with people just because it's a formula. But one of the first things that we end up doing, and this depends on whether we're going to in a keto zone or not, but if we're not, it doesn't sound like he is, I just have people add a couple tablespoons of sweet potato to each one of those formula feeds. And so if you're doing that 4 times a day, then each time we just put a little bit of sweet potato in. What we're doing is we're introducing some actual food. We're not just actual food, but actually fermentable food. You can put a little butter with the sweet potato if you want to, and that'll help some absorption of the carotenes. But really, we're just giving now this body something else to digest. Because remember, digestion is based on the law of adaptive secretion. So whatever it's been that you've been putting in, well, that's what this body's used to digesting, for better or for worse. As we add something new in, you got to go slow and let a body figure that out. But then Then we go from sweet potato. I like other retention starches. Not that sweet potato would be considered that, but like squashes, spaghetti squash, acorn squash, butternut squash. This is the season for squashes. Root vegetables, turnips, rutabagas. Those are all decent things to just start adding into formula-based feeds because they're foods that specifically feed the microbiome of your gut. And the formulas don't really do that. They don't have the kind of fiber necessary to feed the microbiome. So then you're adding that to it. A lot of times that by itself will get rid of a lot of gastrointestinal distress, and it kind of has a mind-clearing sort of a quality about it. So we run the risk of a too complicated answer, but I'm going to give it a try. You put something in your mouth, you chew it up and you swallow it. First thing that has to happen, besides the mastication process and some amylase and some stuff that happens in your saliva, but then the real business of digestion is you have this acidic environment in your stomach. As that acid is exposed to proteins especially, you unravel them so that now the enzymes can get into the crevices and actually break down that protein into some amino acids, tripeptides, whatever, so that you can absorb it. As soon as that material, we now call it chyme, C-H-Y-M-E, leaves the stomach and goes into the duodenum and the jejunum, your body has to alkalinize that. No longer can it be acid, otherwise it damages the tissues, and the enzymes are all based upon that alkaline pH. So here's the essential difference between your G-tube and your J-tube, is your G-tube is pretty rugged. Your J-tube, you kind of got to be a little careful just because some things will irritate the heck out of that jejunum by putting them through that J-tube. When we add food back in, we purposely put it through the G-tube. Just because, even though you're adding in a sweet potato, how much protein's in a sweet potato? Not much at all. Nonetheless, we want to get the body back in the habit of, look, this is the system. This is the process of breaking this down. And so we just generally, if we're going to put something new in that's actual food, we start using the G-tube a little bit more frequently. At our peril in some cases, right? So we have to pay attention to, does that hurt? And if so, what do we have to do about that? It didn't get too overcomplicated, did it?
That was not overcomplicated. That was good. No, that was great.
Hi, I'm Shayna Davis.
Hello.
Hello, everyone. I had to write my questions down.
Oh boy.
I have questions for both of you. So, Dr. Crawford, if you could please explain how do the laser treatments work? How do they work? What's the youngest patient you've seen, and have you seen any kiddos with CP, and what were the results? That's the first question. I can ask Dr. Pease too, but I can hold on if you want to answer.
Okay. So how do lasers work? Oh my goodness. Talk about, he just leaned over and said, talk about complicated answers, right? Okay. Oh my goodness. Okay, so we are beings that are extremely sensitive to light, right? We are designed to have this light source from outside, not from these lights here. We're designed to have this light source from outside actually give our cells energy, right? So think about our bodies having solar panels all over them, right? Those solar panels are called chromophores. And what happens is these photons come in, and just like a solar panel will then transfer that light source into electrical energy, that's basically what our mitochondria are doing, right? And so we're generating cellular energy. But then there's a plethora of other things that you can find in the research. You know, things like we get an increase in growth factors, it increases neuroplasticity, it modulates inflammation. One thing that is noted throughout the research is that laser and light therapy is what's called pleiotropic, and so it's not going to push a system in one direction, it will modulate it, right? And so it's one of those modalities that is extremely safe and effective, okay? There's parameters that we want to work in, and that's outlined in research, and obviously we want to stick to those. But the mechanism is very, very many. Okay, so essentially just think of increasing cellular energy so that cell can then do what it needs to do better. Does that make sense? So if it needs to heal, it'll do that. If it needs to produce a neurotransmitter, it'll do that better, right? Essentially, that's what we're doing. And then your other question was something
I
related
had
to
so
age.
many. Yeah, what's the youngest patient you've seen?
The youngest
My
patient?
son, he's like 18 months, and he
Oh.
has CP.
Yeah.
So just wondering, what's the youngest, and what results have you seen from
Absolutely.
that
Okay.
if you've had a
So
kid with
I've actually worked with newborns. We've actually done a full intensive with a 6-month-old, and we've also done a full intensive with an 8-month-old. And we've done others as well. And the results have been actually phenomenal. One of them I was actually just speaking to someone about. They came in with a diagnosis of failure to thrive. And within a matter of like literally the week that they were there, they completely changed. Now we're like 4 years down the road or something, and all she has is like a little circumduction to her gait. And so we're just still working on that, but that's not that big of a deal. And then in regards to cerebral palsy, we've seen amazing changes. I mean, really, it's just understanding that we have these gamma motor neurons controlling the resting state muscle tone. And if you have increased tone, right? So most cerebral palsy cases come in with this spastic presentation, right? So there's low tone presentations as well, but the majority is going to be this increased tone. But what we have to understand is that the gamma motor neuron coming down from the brain is there to actually develop the alpha motor neuron. And your alpha motor neuron is your functional muscle tone, okay? And so the solution is not necessarily to sever or do a dorsal rhizotomy or anything like that, right? And I'm not saying there's never a case for it, but it's actually to use the body's own systems, the reflexive systems, whether it be primitive reflexes or there's a host of other things, to stimulate those gamma motor neurons to then develop the alpha motor neurons. And we have seen good results. It's going to vary, right? I mean, we've seen phenomenal, results, and we've seen, cases where we get a little bit, I mean, and those are always multifactorial based on what's going on. But we've seen it several times. We know how to navigate that. And 18 months is a phenomenal age. I mean, there's huge potential for neuroplasticity there. So yeah, does that answer your question?
It does. Thank you. And Dr. P.
Oh boy.
I heard people, I know there was a question about magnesium. I've been actually giving him a magnesium bath. So it was mixed with that magnesium, Epsom salt, and baking soda. I found that online. Just wondering if that's cool to do, and if so, how often? And my last question is about the CBD. My son having dystonia, would that help as far as with the spasticity and all that good stuff? And I'm done. And thank you.
Well, the magnesium baths definitely are helpful. When you put other ions in, you're just changing kind of the environment a little bit. Magnesium sulfate is what's in the Epsom salts, and then your baking soda is just kind of have an alkalinizing effect, which does help ionize the rest of the magnesium and the sulfate. Maybe you get better absorption, maybe you get some bicarbonate absorption as well. But all of that has the effect, both bicarbonate and magnesium, of relaxing the body. So, hey, that's a good thing to do. Probably not before going to work, but maybe before bed. The CBD is gonna, it's likely to help. Like we can't make, nothing's 100%. However, the CBD it's a pretty safe bet that that's gonna help his dystonia in one way or another. At the very least, it allows him, while he's going through therapy and doing other things to try to change that dystonia, it allows his body to shift and adjust itself to that dysfunctional nerve pattern. I mean, we know it'll do that.
Can I add just a little to the dystonia? Because I love working with dystonia. One thing that I just want to point out is that every dystonia case is just so different. It presents differently. You can have focal dystonias. You can have, there's so many different things. And whenever we're evaluating any patient, but especially a dystonia patient, you have to ask the question, why is that muscle firing? And the answer is because the spindle was brought to threshold. And so we then have to figure out, why was the spindle brought to threshold? Was it a local phenomenon? Was it a central phenomenon? Was it a combination of both? Was there an autoimmune consideration? Is there an inflammatory consideration? Is there a toxic consideration? And what we often find is that it's a little bit of all that. And so that's where it gets so individualized. I've got a really successful dystonia case going on right now, and talk about the full gamut. We had full-blown neuroautoimmunity, we had chemical toxicity, there were food intolerances all over the board, there was a vaccine injury. There were so many things, right? But knowing that, we were able to really customize care for that person. And we've seen, literally about 80% success so far in reducing his dystonia. So yes, I agree. I think CBD would be a great thing, but there's so many factors to consider with every case, but with dystonia for sure.
Hi. Okay, so I have a two-parter in a sense. Is there something that would assist a child? My son's 16. He's about 16 months post-car accident with a severe TBI and a DAI grade 3. He's in they consider it minimally conscious, but he smiles, he tracks, he does all the things. Is there a way to precipitate more consciousness, more levels of activity for, towards that recovery? In the sense of like using herbal out-of-the-box treatments in that sense?
The answer is yes. And then with the caveat that careful what you ask for, because you might get it. Mm-hmm. There is such a thing as getting too better too fast. And for a 16-year-old, that can be an increasing level of awareness that you're in a pretty crappy situation, and that's really depressing and frustrating. Sometimes for some people that drives them to get better, and sometimes it drives them back into themselves. It's a very personality-driven kind of a thing. And so yeah, but we also have to recognize that there's a timing for that would be more appropriate, and we kind of try to gauge that, try to do some legwork, so to speak, to try to figure out what's going on with him, where's it at, and then start the process gradually and say, okay, how does he manage this? Because there's a huge psychological impact to having a car accident like that, and to whatever degree that he's consciously aware of what happened, that's gonna be both terrifying, it's gonna be, and hey, I'm not the same person. I was the same person a year ago, or whatever time it was 2 years ago. I'm not the same person anymore. Mm-hmm. And that growing understanding is really deeply disturbing. And so we have to sort of take it at their pace. Mm-hmm. But yeah, there's so many things. The problem is the thing that worked on that person may not work on the next nine people. But we try it just to figure it out.
So in conjunction with that, I'm a researcher, and I love learning, and I've watched a lot on the mushroom and psilocybin and microdosing. Is that something that is in your, do you dabble in that? Do you, what's the word?
I'll let you say that one.
Do you, yeah. Is that something that you see?
How much time would you like to spend in jail from this answer?
This is better. This is going to be better at dinner with some drinks.
Right.
Yeah.
So the answer.
And some mushrooms.
So, if I give you an answer, don't 118 of you call my office tomorrow looking for mushrooms, because that's not going to happen. However, I will say that yes, that is a therapy that can facilitate a different level of wakefulness. It is not going to wake somebody up from a vegetative state, but it is a helpful process for how you integrate some of the dysfunctional things that have happened to you and how your nervous system can help figure that out. It's essentially a therapy that gives you the opportunity of taking about a half step outside of yourself and seeing yourself a little differently, and then that allows you to make some changes that you maybe couldn't have seen to make previously. Okay. So there's a medical legal element there, right? So we're talking about illegal substances. We used to talk about cannabis the same way, and now in a lot of jurisdictions it's pretty legal. People have done it. People have done it to excess. People are like, okay, I get it. Been there, done that. If you keep on having to get high every day, you probably got some personal things you got to work out. But we know that that's the case, right? So was it the demon herb that was going to send us down into the moral decadence of hell? No. No, it didn't. In fact, it gets people not even off their couch. Psilocybin, similarly. You're going to take some psilocybin. Are you going to trip and go jump off the roof? Probably not. Will all of your deepest, darkest fears come up and beat your subconscious senseless? Absolutely. That's a given. And so be prepared. If you're 16 and you're in a vegetative state and suddenly all of your insecurities come to the surface, it may not be your favorite place. So we try to take a kinder and gentler way. Sometimes, just from a societal perspective, there's a perception that something that's outside the norm, outside the what's available, there's some magic ticket out there.
Right.
And there are things that can do that. However, you can make a lot of neurologic change that has no ability to maintain itself. Like,
Sure.
we can create new pathways, and you do every single day. You make new pathways in your nervous system. Every one of us does. We used to think that 80-year-olds don't remodel their brains. Turns out they remodel their brains just as fast as 25-year-olds. They just don't do a lot of new stuff, so there's not a lot of net response in the remodeling process. However, children, they remodel like crazy. 16-year-olds, also remodeling like crazy. It's just that once you create a tract, if you don't get some sensory input across that, it's not sticking. We know this.
Yeah.
It takes the sensory input coming back on it. Otherwise, it won't stick around. And so that's functional. That's exercise. That's therapy. That's moving this body. We got to get him to the place where he can start doing stuff like that.
Yeah.
And then he'll be able to wake up as this body comes around. But truthfully, this is a long time that he's been not moving much. So he's going to be stiff. You have to relearn how to tie his shoes and stuff. Relearn how to walk. But he will. I mean, he can. But it's a matter of how do you get that wake up. And there's no magic thing that somebody outside of him can't do. Otherwise, they're stimulating things that will make him just anxious in himself.
He did have serotonin syndrome.
Yeah.
They tried different things, and it really made me, that's what made me look at medicine differently and start going the different route. And, so for Dr. Crawford, do you work with minimally conscious? Do you work with kids like that or teenagers like that?
Absolutely. Actually, quite a bit. Actually, the functional neurology field, a lot of the early cases were from coma patients. And so we have to understand that in developmental functional neurology, we look at the brain as this developmental timeline, right? And so we know that a baby has to crawl before they walk, et cetera, right? We're not going to take a 3-month-old baby and try and stand them up and say, okay, walk, right? There's reflexive systems, there's gait patterning, there's all these things that are supposed to happen in order and in parallel with other systems, developing, right? And so from a big picture standpoint, we have our sensory systems that have to turn on and regulate, and then we have our primitive reflex systems, and then we need our postural reflex systems to turn on, and then we have our core stabilization, we have our vestibular balance, eye movements, and then we go into cognition. And that's how we develop those higher cortical areas, is through that pathway, right? So if we were to try and skip all of that and go straight to cognition, then we're missing a lot, right? We're missing that foundation. So we need to be able to identify, number one, where to start. And, that's the developmental exam. Like, there's a lot, there's different ways. I'm not going to say that we're the only ones that do it. There's MNRI does a phenomenal job. Pediatric PTs, we have our own methodology that we've developed. But someone that can evaluate, where are you? How do we do this, et cetera, that's super important. Now, with consciousness, there's also the vagal system implications. So we have our dorsal vagal system, we have our sympathetic nervous system, and we have our ventral vagal system. That dorsal vagal system is like our fail-safe, right? If we have a trauma, whether it's emotional, physical, something that our system goes, this is too much, we're going to shut down, right? We go into that fear paralysis state. Now, like he was saying, we don't necessarily want to wake up, just boom, we're up, right? Because there's so many things that our limbic system has to process. Maybe our body is like on fire and we're like, oh my God, so we have this system, this coordinated effort of coming back into consciousness, and it runs in parallel with what I was just describing, right? So we can actually evaluate someone and say, okay, maybe they're stuck in between the dorsal vagal and the sympathetic tone, and we need to work on these reflexes and this core stabilization pattern, etc., right? And then we start seeing that progression in consciousness. And the answer is yes, we've absolutely seen people wake up.
Okay, I have a few questions. And thank you all for your questions because I can build on them. So, number one, I heard when this woman over here said that the keto diet helped a lot with seizures and things of that nature. So my question is, as far as starting your keto diet, do you think that would be helpful for someone who also has like neurostorming and things like that to start doing? And if it does, how is it that helps that calm down? Do you want me to ask the other questions too? Or you want me to wait?
Start there.
Start there? Okay.
Start there. So this is a good, okay, so I've seen keto diet be about 50-50 with neurostorms. I haven't necessarily seen it be like the magic thing. But what the keto diet does do is it delivers a high energy, substance to the body, right? So our fat has 9 calories per gram or whatever. I don't remember the exact numbers, but it has a higher energy per unit, right? So it delivers more energy into the system. There's a lot of other considerations to that too. But I haven't seen like a keto diet be the thing for a hypothalamic storm. Do you want to add to that?
I would just add that, especially when you're starting it, the chances of gastrointestinal upset is just really high. It just takes a while for a body to figure out how to digest all this rich food. And then sometimes that irritation adds to the storming. And so then there's where we might kind of try to gradually ease in. We take a look at what they're eating already, and then say, okay, well, what if we just start adding some ketone bodies to this and just see how that goes? And it was like, oh, hey, you know what? That seems like it's an improvement. All right, let's push that a little harder, and make sure that they're okay with metabolizing that.
I'm glad you brought that up. Exogenous ketones could be a way that you could get the benefit, right, but not have to go full keto. Yeah.
We love those butyrates. Let me say that differently. We love the effect of those butyrates. They have a really unfortunate downside, which is most of them taste a lot like vomit. That's a hard sell.
Okay.
Unless you have mushrooms.
That's right.
Okay, so also, I wanted to ask, I know that you were talking about that you do, Dr. Crawford, you do different things to find out what is causing dystonia issues. Like, what are some of those tests that we can say, oh, let me try to look into to find out if there's anything that's affecting our child's dystonia?
A lot of it follows the pattern that Dr. Crawford just kind of described, which is, hey, look, there's a setup here for what it means to sort of be physically present in this world, and it is a lot about what are the thresholds for spindle tension in these structures, and why is that happening? So there's not necessarily like specific like biochemical tests necessarily, although I could think of a couple that might be handy, but by and large, you're really testing that limb, and we use a lot of musculoskeletal ultrasound. Like for me, I can feel a structure, and I can get a pretty good sense of what's going on in there, and then I can ultrasound that thing, and I can really get a sense as to whether that structure is still subject to some neurologic lesion, or whether that particular structure is stuck in itself because it's the hyaluronan.
Well, he mentioned too that also it could be like diet. You need a stool test sometimes to see if there's this or that. That's what I mean.
Anything that causes sort of a generalized irritability in the body is going to increase tone. So if there are things that you're sensitive to in your diet, if there's a place of pain in your gut, you're going to have more tone.
Right. So, okay, thank you. So we should address pain, see where pain issues are. Mm-hmm. We should address if we're digesting food. What else can I add to the checkoff?
Sure.
Can they breathe? How's lung function? If you stay chronically at, say, a 94% O2, you're going to have some tone.
Okay.
Just because that's not an exuberant amount of energy, especially, or amount of oxygen, especially in tense muscles.
Because you need that perfusion of oxygen.
That's right.
Oxygen,
And a stiff muscle
to get to
resists blood flow coming
Gotcha.
into it.
Okay. All right, makes sense. I appreciate that.
So
You wanna add?
are you wanting also like just a list of like,
Yeah, I
lab
mean, if we could
tests?
go
So,
down, because I mean, like you
right.
made a lot of good points. If you know any more.
yeah, totally. I mean, I'll kind of like open up my window of thinking, you know, when evaluating for dystonia. I always want to start with just a comp metabolic, right? We have to see if there's anemias, what's thyroid function like, are there hormone challenges, is there inflammation, those types of things, right? So just a good general just comp metabolic, right? Because if we don't start there, unfortunately I've seen a lot of patients that they've been treating, you know, they've done all the fancy tests, you know, mold and all the things, right? And they've spent thousands of dollars. And we get, you know, the comp metabolic panel, and they have a raging anemia and a blood sugar problem.
That is not an unusual scenario that he
Right.
just presented.
And so that's a foundational thing, right? In fact, I had a patient that they were treated for mold issues for a year. They were a type 1 diabetic, and no one ever checked their blood sugar. But here's the thing, any of those things can alter neurophysiology, okay? From there, I love to look at neuroautoimmune. So I'll run testing like the Neural Zoomer Plus by Vibrant Labs. Comparable would be the Cunningham panel, but it's not quite as robust. That can look at all the different receptors and tissue in the brain and nervous system. Oftentimes there is a neurological autoimmunity. If I suspect a chemical toxicity or environmental toxin, there's panels for that. Gut testing, stool testing, obviously if you have gut dysbiosis or parasitic infections, obviously that can, you know, affect someone too. Not just dystonia, but anything. And then with dystonia, and then of course molds, mycotoxins can be a problem. I've seen that be a challenge for people too. But again, you need to do this in the proper order and not just, you know, one off this thing and go, maybe it's mold, right? With dystonia, I'm going to give this example of the person I referenced earlier, right? So he had this, I believe it was to the left, so his head was just completely stuck left. Facial tone was so much that he could hardly speak. His toes were curled up, right? So he had several different dystonias. What I want to do is I want to evaluate that person. Number one, from that developmental perspective, where are they in this developmental trajectory? But number two, how can I influence that dystonia? Can I make it worse, and can I make it better? Can I find something like a vestibular stimulus? Can I spin them or move their head in a certain way, et cetera, right? We actually found, by working with this patient I'm talking about, when he loads his right leg, okay, when he loads that right leg, so for example, when he takes a step, it worsens the dystonia. And so as he's walking, you see him like this, right? And so when I was working with him, I was just testing, I was doing things. I noticed that, okay, when I loaded that leg, all of a sudden his head stuck. Well, shoot, okay, so I loaded the left leg and he could move his head. And so I just continued to follow that kinematic chain, and we found what we call his stability pose, where we have his cross his right leg up, his left leg's here, he's up against a wall, activating his extensors and his glutes, and he can keep his head straight for as long as he wants.
Because you unloaded it, so to speak.
And so what do we do in that position? Now in that position, I can build neuroplasticity, right? So when he's in that position, I'm now, whether it's eye movements or sensory stimulus or something like that, I'm building plasticity with frequency, intensity, and duration of specific targeted type of stimuli, right? So that we can then, like you were saying, fire those pathways over and over and over again. There's also, if you go to the research and you look at apomorphine tests, so this is a test, this is not a therapy. Okay, let me reiterate that. It's used to test to see if L-DOPA could be a consideration for therapy, okay? But that's not why I use it, okay? But we have used apomorphine in some individuals for short periods of time, because what it will do is it'll give you a window of time where that dystonia basically fades away. It greatly diminishes or it goes away. And so we can administer that. We have anywhere from like a 30-minute to an hour-long window where the dystonia is greatly reduced, and now we can just hammer those systems and build plasticity, right? Not a therapy with the apomorphine, but we can use it to help build plasticity, right? So that's another little trick that we've developed in our clinic. So again, love working with them, but several different things. But you have to, it's, you need to evaluate every little thing and then put it all together.
Okay, thank you. And the last question I have, I know that you work a lot with lasers, and so I was curious if you were to start laser treatment, and I know everybody is different, how do you select a laser and a strength to benefit somebody without making it maybe cause a seizure to be worse or a neurostorm to be worse, so to speak?
Yeah, absolutely. So if seizures are present, we start with a longer wavelength. We'll start with an infrared wavelength because the photons have a lower energy per photon. And what we find is if we do that, we don't tend to increase seizure activity. And then what we'll typically do is we'll start to influence the brain from a secondary perspective. So we'll do things like use a laser over the carotid arteries or the vertebral artery, the abdominal aorta, and we get those secondary and tertiary effects that go up into the brain from using the lasers that way. The majority of lasers on the market are going to be red or infrared. You have your near infrared, you have your mid and your far infrared. The majority are going to be that near infrared spectrum. Those are very safe. In fact, anything that is over 700 nanometers, which is the near infrared range, it doesn't even require a 510K FDA clearance. That's how safe it is, right? The FDA says if that's your wavelength, just go on. You just register with it. Boom, very safe. And then you get into your red, right? Your red has a higher energy. The energy of photons are measured in electron volts. And so when you move from infrared to red, you have a higher energy per photon. Now, with that, it's not that we see a sharp spike in seizure activity, it's just we're giving more energy to the system. And so you can see a transient increase in seizure activity at times. But in our case, we're monitoring things like oxygen saturation, heart rate. We're monitoring for fatigue, right? We're monitoring for how long should we do this on this patient? And then we're stopping, right? And then we're moving and we're changing things, et cetera. And then, we can talk about violet lasers, which we don't start with violet for seizures because that's an even higher energy per photon. But we can move into violet lasers eventually, right? Over time as we build the plasticity in those mitochondria. So does that answer your question? I can go on a lot of tangents.
We have just a few more minutes, so I've got two more questions that have been raised. I'm going to hand the mic off to this gentleman and then one more back here, and then we can go into maybe just some talk with y'all personally.
Thank you. So our daughter born with stroke, and we're not sure if it's after she was born or like 3 months the stroke happened, but she has a 5-factor Leiden blood clotting disorder. So how is she was placed in oxygen when she was born for several hours, and we don't know if it's the lack of oxygen caused that stroke, or when she's born, and how hard, if she's born with that stroke, to be healed, or if it happened after facts. The laser therapy could help in her situation. She's 7 years old now, and we're talking about the left lower brain damage that caused her right side to be.
Okay, yeah. So you're saying can laser therapy be beneficial in that scenario? Okay.
We're not sure if the stroke happened before or after she was born.
Okay, right.
But we know she was low on oxygen when she born. That's when she placed in oxygen for, can't remember, like 2 to 3 hours. And again, she born with 5-factor Leiden. It's our gene. So.
Got it. Yeah. So, we haven't even mentioned HBOT because, Dr. Hartz isn't up here, but he would have had a lot of answers for these people. Why didn't you get up here? Come on, you can answer a lot of these questions. Anyway, but that's a really good situation for hyperbaric oxygen, for sure. Regarding lasers, yes, the answer is yes. It could be beneficial, even with all types of different blood disorders. I've actually seen what were supposedly genetic blood disorders actually resolve And I'm not saying that I cure that. I'm just saying that it just so happens that during the course of our care, we actually resolved, blood disorders. And I've seen genetic conditions even, develop and do things that they shouldn't do, et cetera. Again, remember, laser therapy is that funny word, pleiotropic. And so it's going to modulate, right? We just need to know what wavelengths to use, the dosage that's going to be best, et cetera. And that's, what we do. That's what we figure out. And we already know those parameters for the most part. And so the answer is yes, it can absolutely be beneficial. But if we have like huge deficits, like you mentioned, what we like to do is we like to find ways to stimulate those networks, because laser therapy tends to affect networks that are more metabolically active. And so we do something called co-activation. And so we'll do something to stimulate those networks and then apply the laser therapy so that we can have a more influence over those networks. But the answer is yes, and we've seen similar cases.
I guess I'm finishing. Hi, thank you so much. This is kind of a two-part question, and I think a lot of us probably relate to this. There are pieces, not to be blunt, of my child's brain missing. They're not there anymore. And how can we use these types of therapies? Are they just as effective when those pieces of the brain aren't there anymore?
Is it PVL, periventricular leukomalacia, or?
No, he had a brain injury, and literally the right side of his brain is not there.
Okay.
And he's, I believe in neuroplasticity. I know the other side can pick up because he can walk and he can talk and he can do all kinds of stuff he shouldn't be able to do,
Right.
quote unquote.
Yeah.
But part of his brain is missing. So can we heal the rest of the body and bring those things back together if there's a piece of his brain missing?
Yes. Yeah.
Is that a weird question?
Your brain is a series of networks. The networks will link themselves up, and then the networks link together. So in some cases, you have maybe not the machinery to affect that portion of the network, but in order for the network to reach some point of completion, then the rest of the nervous system will compensate for whatever that is. Now, if you're compensating, it's less than your best. And so yeah, it's not going to be probably as good as if he wasn't missing those elements of his brain. But once you get it in play, now if there is something that you feel he's kind of weaker in terms of a skill set or what have you, in terms of functionality, well, then you direct your actions that way. You say, okay, well, then let's work on this. Because this brain is pretty plastic. I mean,
Okay.
Norman George talks about a case at the beginning of the brain that changes itself,
Yeah.
This fellow who has this massive stroke, it's the Bakirita story. Here's a guy that had 2/3 of his brain missing, and, he still goes on to be teach poetry at a PhD level and climb mountains until he dies on the top of one. That's pretty incredible. But a lot of that is because this brain is an extremely redundant system of networks.
Okay.
And so it's a matter of how well do you get that network to get set up.
Okay.
And it's a very functional kind of a thing. You got to get a system into a place where it has something to adapt to. And then it'll adapt. He'll adapt. It's just a matter of creating the right kind of scenarios for him to adapt to.
Okay. And another question, kind of along the same lines. Because he's hemiplegic on the left side and he suffers from tone, he's had some different orthopedic surgeries done. Could some of the therapies that both of you do, could those surgeries prevent some of your therapies from working because they've been changed physically?
I think speaking for both of us, we take a very, it's getting late.
Like, did we do too much? Did we do too much to those pieces of his body? And it's like...
No, because both of us have a similar sort of mindset with this, which is we're looking for functionality.
Mhm.
Like, where is this person? How are they doing?
Yeah.
I don't care if the pieces are missing. What do we need to do to get you to this place? If the pieces aren't missing, what do we need to do to get the brain to make use of some other pieces to compensate for that, right?
Okay,
Like,
yeah.
if you lose your auditory system, you go deaf, you can teach yourself how to hear in different ways. If you go blind, you can teach yourself, you can make tick sounds and that. And you can make yourself be an echolocation device. You have to calibrate yourself to that, but everybody can do it. The ticket is, how does your child calibrate himself to where he's at in this moment? What's his capabilities? What are the limitations? And then how do we set that up in a functional way? What do you want him to do? What does he want to do? Then let's set that as a goal, and hopefully it's something that he's really interested in, and then let's get there. What's it going to take to get there? Now, it may not be a straight up, you want to run a marathon? Well, let's start running, kind of a thing. But there might be some fundamental background or groundwork that you have to come up with. Mm-hmm. But at the same time, we're taking a functional approach. We're going to say, hey, who's this human? What are they doing today? What's not going well? What can we do to make it go better?
Thank you.
There's, I even have a reference just with the pontocerebellar atrophy case. It's a rare genetic disorder, even on MRI, there's little to no cerebellum on this kiddo. But the mom's she's amazing. She's a hellraiser, right? There's like everyone else in here, right? And when someone tells her, your kid's never going to, ... she says, watch and see. And so they've, employed a lot of the strategies we do. I'm rather certain that they're working with Dr. P. They're doing all kinds of things. The cerebellum's actually growing. I have an image of it on my wall, okay, because it's amazing, because it shows that that's a load of crap. Never tell anyone that they're not going to whatever. The brain will never stop changing. Will never stop changing. And I love that he referenced the 80-year-olds, because that was a hospice study done in this population, in hospice care. This is the population that there should be no neuroplasticity. They're on tons of opiates and medications, and they're old and they're dying. Let's see if they have neuroplastic change. They did. The brain will never stop trying to change, period. It won't, right? So as long as you can direct that person, like he was talking about, there is the potential for neuroplasticity.